I will be kind of setting the stage a bit for brain metastases, and I will tell you, I'm going to mind the time because, again, being respectful of our interpreters, they have asked me to speak slower. So I will go through this data and kind of give you an overall introduction, hopefully at a pace that will be appropriate for all. So starting with, these are my disclosures, and I would say for obviously, for brain metastases, it's an increasingly difficult problem that we're facing. We're actually doing very well in terms of controlling systemic disease, and our patients are living longer with metastatic solid tumors. And the expectation is up to 30% of those patients will eventually develop brain metastases. And we know that the number, even today, outnumbers the number of primary brain metastases, primary brain tumors, almost 8-to-1. So it's really statistically the most common problem we face from cancer in the brain. And so if you look at the, kind of the distribution of what goes to the brain, we always talk about the big three: lung, breast, and melanoma. But if we work at a place like MD Anderson, we actually have a lot of those less common diseases that go to the brain, like GI cancers and ovarian and prostate as well. In my day job, when I do my own clinic outside of the brain metastases clinic, I'm a melanoma physician. And so it is not surprising that my focus is on brain metastases and melanoma because it is an extremely common issue. In fact, we consider when our patient presents with metastases from melanoma, we expect to face brain metastases almost every single time. Up to 80% of patients by the time of death will have metastatic disease to the brain. And we also know that of all cancers, you see the survival here 10 years ago used to be 20% at 1 year. And of all cancers, melanoma is known to have the highest incidence of neurologic death. So if you have metastatic disease to the brain, about 30% of patients will die of that. If it's melanoma, closer to 50% of patients will die of neurologic death. And I can tell you, melanoma is a disease that has led the way in oncology in terms of both targeted and immunotherapy. And we've had, in the last 10 years or so, we've had 13 drugs approved or combinations approved for the treatment of patients with melanoma. And most recently, just in the last actually 4 months, we've gotten a new combination approved, which is relatlimab and nivolumab. So as we make this progress in metastatic disease, the question is, how does that apply to patients with brain metastases? And so I will summarize that data for you. We actually know that with targeted therapy, so BRAF targeted therapy, there's only been one prospective study led by my colleague and the chair of our department, Mike Davis, where patients with untreated brain metastases were given the combination of dabrafenib and trametinib. And what we found with that study is that you get high responses in the brain. You get about 55 to 60% of objective intracranial shrinkage of disease. So really quite impressive in that regard. However, what we've learned very quickly is that the progression-free survival, how long you control the disease in the brain, is actually only about 5.7 months, which is about half of what you can do for the disease outside the brain. So targeted therapy, very good at shrinking disease quickly. However, it doesn't keep it under control for too long. Immunotherapy is a slightly different proposition. We know that single-agent immunotherapy is capable of inducing intracranial responses. So we've known that from the days of ipilimumab as a single agent. It has a response in the brain of about 15%, the same that you would see with extracranial response. And we also know that if you're on steroids at the time of treatment, this is what is called cohort B in this study, those patients have almost no response to treatment. Single agent PD-1 has been used in 2 different trials, and in both, the response rate is about 20%, 18 to 20%. So again, about half of the response that you get outside the brain. But importantly, if you get a response in the brain, it's usually concordant with extracranial responses, and it's usually durable. So, we have a very long duration of response. And again, half with single agent, half of what you get outside the brain. But when we use combination, and in this case, we use immunotherapy with ipilimumab and nivolumab, and just to be clear, in this situation, we use the ipilimumab dose for melanoma, which is 3 milligrams per kilogram. So it's a higher dose. we can induce a high rate of response. So now 55%, which is equivalent to what we do outside the brain. Importantly, we cause that we induce that response very quickly. The median time to response is 1.6 months or 6 weeks, actually the first time you check. And then now we just published in Lancet Oncology the update to this that shows us that the responses are durable at 3 years. So 87% of responses were continuing at 3 years. And this is what the PFS curves intracranially look at 3 years. So once you get, those 40–50% of patients that could progress up front, everybody else that has gotten a response gets a prolonged control of the disease. Now, importantly, the 101 patients in which we saw that were asymptomatic and not on steroids. I will have to specify that the size of the lesions didn't matter. Actually, the median size one was 1.6 centimeters, so it's not necessarily subcentimetric, but there was no steroids, and that's the biggest deal. When we treated patients on the same study, we had 18 patients that we treated that were either having symptoms or requiring steroids to control their symptoms. The response rate was a lot lower. It was only 18%. So we know that it's a smaller response rate. However, what you see on the PFS curves there is that those patients that respond in the brain, even with symptomatic disease, get a durable response. And so when we looked at the 3-year survival, again, now the 3-year survival is 72% for this population that's, otherwise had a 1-year survival of 20% just 10 years ago. But I want to point out, and I think this is relevant to multidisciplinary discussions, we actually did a landmark analysis in this study. And when you looked at the response, if the patients had responded at 12 weeks, so you look at who was a responder or non-responder only at 12 weeks, so early on, that predicted survival. A responder at 12 weeks, the overall survival was 92% at 3 years. So really very important proximal endpoint that we can use to decide, how well those patients are going to do long term. Similarly, again, for patients with symptomatic disease, the survival was a lot more limited. So we do know that this is a completely unmet need, that this is an area where we really need to think about how to improve the outcome of patients requiring steroids or symptomatic at the time of diagnosis. And so to start thinking about this, so inducing an immune response in the brain, almost no matter how you induce it, with single agent or with combination, you're capable of having a durable response, but the presence of steroids impacts immunotherapy and takes away the ability to have these durable responses. And so the idea of taking the steroids off, or a steroid sparing approaches, is very important. And so from a pharmacological perspective, there is some consideration for using VEGF inhibition. So we all know that Avastin is capable, or bevacizumab is capable of decreasing swelling in the brain. So perhaps that would be one way to avoid the immunosuppressive effect of the steroids. There are some other VEGF-R1, 2, and 3 inhibitors like lenvatinib that are being considered right now. So those are two things to think about. But what I'm going to share with you in the next few slides is the idea of cytoreduction. The idea of, we know that these symptoms and this massive edema usually comes from 1 or 2 lesions. Can you do something about those 1 or 2 lesions, be it surgery-targeted therapy or SRS, to take away the need for steroids and then give immunotherapy the chance to have an intracranial response? And so the idea of using surgery has been actually pioneered by at Mass General, and Dr. Alvarez Breckenridge is now one of our faculty members at MD Anderson. And what they published in The Oncologist is that, in patients in which they actually used surgery as a bridge therapy, so you take away the one lesion that was causing a lot of swelling and requiring steroids, those patients ended up being able to go on to be treated with combination immunotherapy, and they had the best survival of all of the patients that used any other sequence. What we've also considered doing is the use of targeted therapy. So we are running a trial at MD Anderson of using BRAF and MEK inhibitors along with immunotherapy. And what you see with this waterfall plot is a lot of patients do respond. The patients that are red, or the red bars, are for patients that have already seen prior immunotherapies or PD-1 refractory. They still respond. Importantly, the patients with the asterisk are actually patients that have untreated brain metastases and indeed had a great response. We actually had a response rate of 67% in the brain with this combination. Importantly, the progression-free survival was the same, whether those patients had brain metastases or not, indicating that we actually managed to control the brain this way just as well as we controlled extracranial disease. Excuse me. One other study that was just presented at ASCO by Dr. Doomer, and I was personally a senior author on the study, is Tricotel, or a study of the combination of atezolizumab, PD-L1 antibody, in combination with vemurafenib and cobimetinib. That's a triplet that is FDA approved in the first line for patients with metastatic melanoma. And this was the first time we studied it in patients with intracranial metastases. And so what we found in this study, if you look at asymptomatic patients, the response rates ended up being in the order of 40% or so, so about or even a little less than the dabrafenib and trametinib alone. But for patients that were symptomatic, we had a pretty good cohort, 24 patients that were symptomatic and on steroids. And we designed the study to actually measure, record the amount of steroids at the start of therapy and then look at it after 4 weeks. The regimen is Vem and Cobi together for 4 weeks, and then you give immunotherapy. And indeed, a lot of those patients ended up being able to get off steroids in that 4-week period. And when immunotherapy was introduced, we got a response rate of closer to 60%. And for the first time, a PFS in the brain with a targeted therapy approach that was closer to 10 months. So it seems to be a reasonable approach to try to use targeted therapy for that goal. Obviously, SRS is a huge component and is a very, very effective treatment. It's sometimes has success rates closer to 100% if the lesions are small. And we know that there is some evidence of synergy. And we've seen a ton of retrospective studies showing us that, if you combine immunotherapy with SRS, you get better outcomes. This is one of the earliest studies from one of my colleagues, Annie Silk from Michigan at the time, that shows that if IPI was part of the regimen along with SRS, patient survival was so much better. And so the idea of combining immunotherapy with targeted therapy is being studied in a randomized fashion. This is an Australian study that's using ipi-nivo and SRS upfront versus waiting until patients have progressed and using SRS then. So that could be another approach where you could eliminate the need for steroids upfront and maybe able to give intracranial responses to combination immunotherapy. I will briefly mention the fact that, immunotherapy could have activity in other malignancies as well. And, the current approach is, if you've seen extracranial activity, does that translate into intracranial activity? And we know that with lung cancer, that's been the Pembro study I showed you with melanoma was actually done in both lung cancer and melanoma, and again had about a 20% intracranial response. We're awaiting the results of a study that Mehmet Altan and Jing Li at MD Anderson are running together for ipi-nivo for the patients with brain metastases from lung cancer. And then it would be interesting to see whether combinations with chemotherapy would be effective in the brain as well, mostly because of the immunotherapy aspect as well. There's been some evidence of responses in other diseases where immunotherapy is getting kind of traction, and I would mention here breast RCC. So in breast cancer, just very briefly, obviously we think about brain metastases from breast cancer to be primarily in the two populations that highest risk, the triple-negative breast cancer and the HER2-positive breast cancer. So we know that for HER2-positive breast cancer, HER2-directed therapy for the brain with tucatinib has made some significant inroads. But I do want to highlight that for triple-negative breast cancer, it's the first breast cancer in which immunotherapy is showing activity. So we hope to be able to show some activity intracranially from immunotherapy there. With renal cell carcinoma, that's a disease that's closer to melanoma, and that we use immunotherapy in it much more readily. And again, the data is very limited. It's only about 40 patients worth with single agent PD-1, but again, gives you the same outcome, about 13-14% response. But when you get a response, it's always durable with immunotherapy. And I think that's really, really important to know. There's a smaller study that was done with ipilimumab and nivolumab, and it showed a response rate that was not as high as you would expect, at least not what we've seen in melanoma, where the response rate was only, again, about 20%. So the differential from single agent was relatively small. But again, you see that plateau when we see the response, when we see that durability, the plateau and the impact on survival. So as we think about this, what are the next steps? How do we decide what are we going to be studying next? And how do we learn from the patients that we have, the tissues that we get from those patients, and how do we actually prioritize which drugs to bring to brain metastases? So I would tell you the first thing is that as much as I may have convinced you that immunotherapy is capable of inducing these durable responses in the brain, we really don't understand exactly how it works. So one of the goals of what we do at MD Anderson is actually collect the tissue from those patients with brain metastases that have been treated with immunotherapy and have resections, and trying to see whether how does the immunotherapy really exert its effect. Is the immune activation happening extracranially, or are there very specific clones that are coming from intracranial tissue? So we're doing this in collaboration with the Traction team. This is supported by the Moonshot. And the Traction team is actually one of our closest collaborators in this space, where they're developing immune competent functional models in mice, where we can actually ask the question, can you use immunotherapy in an immune competent model? Can you induce intracranial responses? Can you affect survival? And then if we manage to study that in those models, and you see there we have melanoma, we have breast, we have lung and kidney cancer, then we can actually start prioritizing which drugs we should bring to the clinic. And I can tell you, the way that we keep the clinic and both translational and preclinical models very close is through the brain metastases clinic that we have together. I co-lead this with Dr. Lang and Dr. Lee. And we have an incredible group of talented folks, 5 neurosurgeons, 5 or 6 radiation oncologists, 8 medical oncologists, neuroradiology, all working together, trying to see those patients in tandem. We see patients all together in the same day. And also we bring clinical trials to that population. So this is an example of a study that we had funded through an alliance trial. And we had 2 targets that were initially thought about in melanoma, but they were applicable to lung cancer and breast cancer. So we include multiple histologies, and we include SRS as well. And this is another, kind of example of some of the studies that we're running. We have ipilimumab and nivolumab and cabozantinib in RCC. Dr. O'Brien is running a study of tepotinib. We have pembrolizumab and lenvatinib, and again, we have tucatinib and TDM1 in patients with breast cancer. So I'll end maybe with a couple of thoughts about the window of opportunity studies, in the presence of people like Dr. Lang here, maybe to mention he pioneered, obviously, this approach. But I would say, again, as we use our tissues to understand what's happening, as we use our preclinical models to tell us which trials to do, the next question is, how do we study these drugs as fast as possible? And I can tell you, with window of opportunity trials, you get an immediate readout on the pathologic impact of treatment. You have an ultimate translational experiment. And I think it would really help us understand how these drugs work. It is difficult to run those studies. And this is one of the goals we have, to be able to do this in a harmonized fashion so that we can pull data from multiple studies from multiple sites, hopefully, nationally and internationally, and really try to standardize the way we analyze these. So I have a couple of examples here from melanoma, but I'll run through them because I'm running out of time. I can tell you that we use the neoadjuvant setting in melanoma, very similar to what window of opportunities can do. And we managed to develop guidelines that now harmonize neoadjuvant therapy in all of melanoma. And not only that, but it also teaches us how to do the translational components of this. And we've managed to, publish pooled analyses in Nature Medicine from across the world to help us do this and actually uncover new biology. So again, I don't have time now to go through all of it, but I'll tell you that the discovery that B cells have a role and tertiary lymphoid structures have a role in immunotherapy response was from pooling data from these neoadjuvant studies done at MD Anderson, done in the Netherlands. This is from a Pasunio in the Netherlands and Australia. And we actually validated that in renal cell carcinoma and validated that as well in sarcoma. So basically, you can really use a window of opportunity trial situation to actually uncover new biology. And I think that is so important and so needed for patients with brain metastases. So In conclusion, I'll say that, we have a high rate of durable responses when you use immunotherapy in combination. We still have a lot of work to do. We want things that are more effective. We want things that are less toxic if possible. We can use, again, cytoreduction and different steroid-sparing approaches to help symptomatic patients. But really, the key is really understanding what is happening at the tumor level, what's happening between a tumor and a host interaction, and trying to use preclinical models to help us prioritize which studies to run. I am very fortunate to be here with this multidisciplinary group and working in the brain metastases clinic, but I really look forward to national and international collaborations to be able to have a better way of studying this problem and really fixing it and coming up with new ideas for it. So with that, many thanks to a lot of folks. Most of them are in this call, particularly Fred for being an incredible partner in this, and other members of the Brain Metastases Clinic. And I will stop here and we'll be happy to take any questions.